Thank you for joining us. We are in the Well Baby Nursery with baby girl Emma, who is a 40-week gestational age, full-term African American infant girl, born approximately 1 hour ago in our delivery room by normal spontaneous vaginal delivery with APGAR scores of 9 and 9. Her parents are not present. This is her first Well Baby newborn exam. I'm first going to begin by washing my hands and donning clean gloves. And then I'm next going to gather my equipment, my stethoscope, and my ophthalmoscope. So beginning with Emma's general appearance, she is in a quiet, alert state. She has symmetrical movement of all extremities, upper and lower. She has flexed tone of her upper and lower extremities, which I would expect for a newborn at 40 weeks gestational age. She is pink in color. There's no signs of any bruising or any birth trauma. She does have some vernix still present. She was a normal vaginal delivery. Her skin is pink and her color would be considered appropriate for her ethnicity. She's not showing any visible signs of distress. Her skin is warm to touch and is well perfused. Her nutritional status appears to be adequate looking at her skin, her size. Her birth weight was 3.8 kilograms. So she appears to be a healthy, full-term infant girl. Next, moving on to assess Emma's head, her ears, her eyes, her nose, and her mouth. She has no evidence of birth injuries such as a cephalhematoma or caput succedaneum with inspecting her head. I'm going to begin with her anterior fontanelle, which is soft and flat to palpation, and palpating her coronal suture, intact. No edema is palpated, followed by her sagittal suture, which is midline, and then her lambdoid suture, intact. No edema or swelling present or palpable. And last, her posterior fontanelle, just soft and flat. Next, moving to Emma's ears. The pinna of her both ears are well formed and the cartilage recoils easily, which is expected for a full-term newborn. Distance between the eyes and the ears appears to be appropriate and evenly aligned. The distance from the inner canthus to the outer canthus of her eye to her external ear, if we draw an imaginary line, it's even. If it were the position of the ear was lower than that imaginary line, I would be concerned with possible trisomy 21. Her eyes are clear. The sclera are white. There's no evidence of any conjunctival hemorrhage. I shine the light to check her visual tracking. She tracks. And then assessing for the presence of the red reflex. The red reflex is present in both eyes. If it were not present, I would be concerned about possible congenital cataracts. Looking at Emma's nose. So all newborns are expected, all healthy newborns are obligate nose breathers. And for those infants who have choanal atresia, or we're suspecting it, I would expect that at rest she would be cyanotic in color. However, when she cries, her color would turn pink if she had choanal atresia. But she has no signs of nasal flaring, and her nares appear to be patent. Looking at Emma's mouth, necks, lips are pink, which is I expect. If I insert a gloved finger in her mouth, we are eliciting the sucking reflex, and she has a strong, consistent suck on my finger. As I feel and inspect her palate, I see no evidence of a cleft palate, and I'm going to shine the light to inspect her mouth. The mucous membranes are nice and pink. Assessing Emma's neck for any redundant skin or webbing of the neck or masses. I don't appreciate or palpate any masses or any evidence of redundant skin, which if it were present would be concerning for Noonan's or Turner syndrome. Looking at inspecting the clavicle for signs of birth injuries, fractures. Her clavicle is intact, and she's tolerating my palpation of it without any resistance or distress. Assessing Emma's range of motion to assess for torticollis. If I turn her head to either side, she passively rotates her head easily without any appearance of a preference for one side over the other. I'm next going to begin the assessment of Emma's chest and her lungs. So looking at her breathing pattern, her respiratory pattern, respirations are even and symmetrical. She does not appear to be in any respiratory distress. She is not displaying any audible grunting. She's not showing any retractions. And I already noted that she doesn't have any nasal flaring. I'm going to auscultate her lung fields, both anterior and posterior. And she has clear bilateral equal breath sounds on both sides. Looking at her breast buds, they're about 3 to 4 millimeters in size, which is appropriate for a full-term infant girl. And her areolas are raised on both sides, and that's also expected for her gestational age. I'm now going to listen to her heart sounds and palpate for thrills. I'm going to begin with listening with the diaphragm of the stethoscope first. Left lower sternal border. Left upper sternal border. Right upper sternal border. And then the apex. I appreciate S1 and S2 heart sounds. No evidence of a murmur. Palpate for thrills. I do not appreciate any thrills. And then I'm going to palpate for the point of maximal impulse, which is at approximately the 4th intercostal space at the midclavicular line. And the point of maximal impulse is easily palpable. Her precordium is quiet. I'm next going to assess her peripheral pulses. beginning with her brachial pulses. +2 in quality, normal and equal radial pulses. Our +2 in quality, normal and equal. Her femoral pulses. Normal and equal. Her posterior tibial pulses are normal and equal. And last, her dorsalis pedis pulses are normal and equal. Her abdominal assessment is next. Emma's abdomen is soft and rounded, as I would expect it to be for a healthy full-term neonate. There is no evidence of distension. I do not see any visible bowel loops. I'm going to gently palpate her abdomen for any masses, and I do not detect any or any tenderness to my palpation. I'm next going to palpate and assess Emma's liver 2 centimeters below the costal margin on the right. And the liver is easily palpable, does not feel boggy or tender. Now I'm going to assess her spleen on the opposite side. Followed by the assessment of her kidneys, beginning with her right kidney. And then her left kidney. Now we're going to look at her perineal and perianal area. Genitalia are appropriate for a full-term infant girl. She has a prominent labia majora with an adequate amount of fat present, which indicates a healthy nutritional status. No evidence of clitoromegaly. The labia majora completely cover the clitoris, as expected. She does have a white, pink, reddish discharge vaginally, which can be attributed to maternal hormones and is normal in infant girls. And then assessing her anus for patency, she appears to have a patent anus. And from this view, I do not appreciate a sacrodimple. But I will also turn her over to inspect her back completely to assess for that. Next, moving on from the GU system to the musculoskeletal system, her tone is appropriately flexed. She has symmetrical movement of all extremities, which would be expected for a full-term infant. Flexion of both her upper and her lower extremities. Inspecting Emma's spine, I'm going to turn her over and inspect her spine for any evidence of scoliosis. Her spine is evenly aligned and symmetrical with no curvature to the right or to the left. Looking at her gluteal folds for any asymmetry. Her gluteal folds are symmetric. If they were asymmetrical, that would be concerning for a hip abnormality, such as developmental dysplasia of the hip. And then assessing for any spinal abnormalities. I do not see a sacral dimple or the presence of it, and I did not appreciate any spinal dysgraphisms. She does have Mongolian spots over both buttocks, which is normal and common in infants with her ethnicity. I'm going to turn her back over. No sacral anomalies visualized. Now I'm going to assess Emma's hips for hip dysplasia. First, going to perform the Ortolani maneuver, in which I will flex her hips and then abduct her thighs. And what this does is this produces a reduction of the femoral head, of the dislocated femoral head into the acetabulum by abducting the thighs. If there is a palpable clunk, then that means that the femoral head has slipped from a dislocated position into the acetabulum. And then next is the Barlow maneuver, in which the hips are flexed and the thighs are now adducted. And what that assesses for is whether the femoral head can be dislocated from the acetabulum. So if there is a palpable clunk with this maneuver, that means the femoral head has slipped over the edge of the acetabulum and the hip joint is unstable and dislocatable. Emma has 5 digits on each hand, and she has 5 digits on each foot. No evidence of syndactyly, webbing of the digits, or polydactyly, extra digits. Looking at her hands, I do see a single crease across her palm, which is considered normal in newborn infants. At the same time, that can be associated with trisomy 21. Looking at Emma's feet, her feet do not show any evidence of deformity, such as club foot. She has appropriate spacing between her first and second toes on either foot. If there was to be a wide distance or space between the first and second toes on each foot, there would be a concern because that's associated with trisomy 21. Next, I'm going to assess Emma's neurologic status. We've already indicated that she is in a quiet alert state. We're going to assess all of Emma's reflexes, beginning with her, we've already assessed her sucking reflex, which is present. The rooting reflex is elicited by stroking one side of her cheek, and she instinctively turns her mouth towards the stimulus, or turns her head towards the stimulus. The rooting reflex is present, the sucking reflex is present. Moving down to the palmar grasp reflex, if I place a finger in each hand, she instinctively tightens her fingers around my gloved finger and resists me letting go. The palmar grasp reflex is intact. The tonic neck reflex, if I turn her head to one direction, on that side that the head is turned, she instinctively extends her arm, and then the opposite extremity, she raises it or flexes it. And then assessing for the gallant reflex, if I turn her in a dorsal ventral position and take a finger and stroke the side of her spine on one side, she instinctively turns her pelvis to that stimulus on that side. Likewise, if I stroke alongside her spine on the opposite side, she instinctively turns her pelvis towards that side of that stimulus. Then the moral reflex, if I support her head and neck and just gently lift it off of the bed a few centimeters and then let go and release her, and the support of my hand from her head, she instinctively extends her arms and then flexes them. And then the stepping reflex, holding her upright with her trunk over her body and gently letting her feet touch the surface, she begins to make stepping motions with her legs and with her feet. Lastly, the Babinski reflex. So if I stroke the outer soles of her feet, she instinctively extends and fans her toes outward. There's a present Babinski reflex. All reflexes are present and intact. In terms of her behavior, she has tolerated this exam very well. She has remained calm and quiet and hasn't shown any distress with any of the maneuvers or any of the positions. This is a healthy, full-term, well-nourished, 40-week gestational age newborn girl, and she does not appear to be in any distress or any pain. Has tolerated the well baby exam very well.